Afternoon, everybody. My name is Ian Sheldrake, and I'm a principal with the Nous Group based in our Perth office. And over the last 18 months, I've been leading our work with the WA Primary Health Alliance. And it gives me great pleasure to introduce the second in a series of webinars hosted by Dr. Norman Swan on the long-term implications of the COVID pandemic. These webinars have been organised by the WA Primary Health Alliance, are sponsored by the Nous Group, and are raising money for a great cause, Youth Focus. I'd like to acknowledge that Norman and our guest experts today have donated their time to participate. So on behalf of the WA Primary Health Alliance and Youth Focus, I'd like to thank them all. I'd also like to acknowledge the traditional owners of the various lands that we're all participating from today and pay our respects to their elders past, present and emerging. The primary format for today is going to be a facilitated discussion with an expert panel. We'd like to invite you to use the question and answer function within this Zoom meeting to post questions throughout, and Norman will come to those as and when during this session. But you haven't come here to hear from me, so I'd like to hand over to Norman to introduce today's topic and our guests. Thank you very much.
Thanks very much, Ian, and thank you all for joining us. And I too would like to acknowledge country. I'm sitting on Gadigal land, the Eora Nation, and pay my respects to elders past, present, and most important of all, elders who are emerging. And I also want to pay tribute to Aboriginal and Torres Strait Islander communities throughout Australia, who it's been a triumph that they have had virtually no COVID-19 as far as I'm aware. And why? Because they took control. This is a classic example of how community control works, how communities can take responsibility for themselves, and when they do, things work. And that's a message for non-Indigenous Australia, because this pandemic has come under control. You know, lots of people have done great work at federal government level, state government level, but it's also communities have come to the fore. And that's partly what today's program is about. It's a lot of it is about community, because the aged care community have suffered mightily, at least in Victoria, but in terms of the 900 odd deaths, most of those have been in the elderly. And unfortunately, many of those have been in residential aged care facilities. And what happens, and it's like any pandemic, pandemics reveal vulnerabilities. Pandemics are about human behavior as much as they are about the biology of a virus. And when you've got a system that's under stress and strain, and we all knew that the aged care sector was under stress and strain. I mean, we've got an aged care Royal Commission going on into the quality of aged care. And we have had, unfortunately, some outbreaks, a couple in New South Wales and a lot in Victoria, particularly in the private sector. So what happens with aged care moving forward? What have we learnt? What can we do better? And a lot of people are thinking about that. How do we engage? How do we actually make that interface between the aged care sector and healthcare work? Is it an artificial interface? For example, in residential aged care, whilst we want to build residential facilities which feel and look like homes, the reality is that a large proportion of people will die there, and therefore they're also health facilities too. In a sense, you've got to hide that from the fact that it's a home. And there's a whole discussion about palliative care moving into residential aged care to actually integrate that humanistic form of healthcare into aged care. Anyway, I'm blabbing on far too much, because each one of the panelists knows 450 times more than I do about this. I'm just here to facilitate this. We've got Professor Michael Kidd, who is Deputy Chief Medical Officer, who's Professor of Primary Care Reform at the Australian National University, who had a very senior position at the medical school at the University of Toronto before coming back to Australia to take up the Deputy Chief Medical Officer position, has an honorary position at the Murdoch Children's Research Institute. But Michael has been a pioneer throughout his career in general practice and in primary care, going back to the early days of the HIV pandemic, another pandemic. We've had plenty of pandemics, unfortunately, and the HIV pandemic has affected 18 million people, 33 million deaths. And Michael pioneered general practice with the community, again, the community taking control of the pandemic, which was again one of the triumphs of Australia's response to HIV, and general practice being at the fore rather than specialists, and certainly in partnership. And Michael, though, has been a huge proponent of primary care and president of the college as well in times. Welcome, Michael.
Thank you, Norman. Great to be here.
Professor Sue Curl is another one of our guests, our three guests today. Sue is professor of aged care, the health and, sorry, I'll just get this right. So I've interviewed you so often, I should get this right. The chair in healthcare of older people at the University of Sydney, has run the geriatric service at Hornsby Hospital, works in the south coast of New South Wales in Batemans Bay, and is probably the only person that we'll have in this webinar series who's an Emmy winner. And an Emmy winner discovered in the last 24 hours. So congratulations. You know, where's your frock? You know, I don't seem to, but we'll work out, I'll tell you in a moment why and how. Sue won the Emmy in the last 24 hours. And last but not least is Stephen Tullen, who is a principal at NAUS and has had a long career in aged care, running major facilities, major chains of aged care facilities, knows this from the inside out, and now is working as a consultant in this field. So welcome to you all. So Michael, I'm going to leave the tantalizing Emmy hanging there, and you're not allowed to give it away. So just, I mean, it's been a baptism of fire in the Commonwealth in terms of aged care, because you set the standards for aged care and monitored that. Let's not pick over the bones here, but let's talk about moving forward. What needs to be done in the aged care? What have you learned, and what needs to be done?
Thanks, Norman. So there's huge learnings from what's happened in aged care, and of course, with the Aged Care Royal Commission running at the same time, we've had a special report from the Aged Care Royal Commission on COVID-19. Now, I understand that many of the people who are joining the webinar today are people working at PHN's primary health networks across Australia, and I particularly want to focus on work which the PHNs have been doing to support aged care. For example, at the start of the influenza season, all the PHNs around the country made sure, working with their local GPs, that every resident and every worker in every residential aged care facility across the country had been immunised against influenza, so that we avoided that looming potential of a double whammy of COVID-19 and influenza occurring throughout the winter. Our PHNs have been very active in the distribution of personal protective equipment in areas where we've seen community transmission, and of course have been very active in setting up the general practice respiratory clinics across the country. So just want to say a big thank you to everyone who's online for the work that they've been doing for us. But there's going to be a lot more to do in aged care, and I think it's really important that we do learn the lessons from COVID-19, even though at the moment we're only partway through the pandemic. One of the things which has been very obvious is every resident of an aged care facility has a GP. But when we've had the outbreaks occurring, the GPs have not necessarily been very well engaged in the responses which have occurred. And that has actually now turned around. And one of the things which turned it around in Victoria was establishing the Victorian Aged Care Response Centre, the initiative between the Victorian Government Department of Health and Human Services and the Commonwealth to get better coordination of the response in aged care when we're having that very high level of community transmission occurring during the second lockdown in Victoria. I think we've also seen with the restriction of visitation, the use of technology start to move into aged care for the first time in many aged care settings, and the ability to have appropriately cleaned iPads so that people were able to interact with their loved ones, but also interact with their healthcare providers. And so we've provided this opportunity to have more engagement by general practice into aged care. One of the recommendations that came out of the recent Royal Commission report was the need to focus on the involvement of allied health and of mental health therapists in aged care, and particularly recognising the impact of prolonged lockdown on the residents of aged care facilities, and the risk of people becoming physically deconditioned, but also the risk to their mental health and emotional health and well-being through being separated from their families and their loved ones. So, Norman, there's so many different areas which we could touch on. I think the preparatory work which has happened through the Aged Care Advisory Committee of the AHPPC, which I've been privileged to chair for the last couple of months since it was established, looking at providing guidance and support to aged care facilities on what to do in preparing for pandemics, in preventing pandemics, in responding. But very importantly, the work that we're doing at the moment is on recovery and looking at how we support people on in their recovery journey as well.
So let's talk a little bit about coordination and put aside COVID-19 for a little bit, because is this issue, which has been a long-standing issue, is that some GPs just love working in aged care and palliative care, and some GPs are disengaged, as you said. That's partly about remuneration. There's lots of different reasons. How do we make that work better in terms of people's health and well-being care with the facility itself? Because there's only so much that a facility itself can do. When there's expertise, you can't expect a resident GP in residential aged care, although there are some private aged care chains that do have their own doctors, but that's not necessarily the solution. Just give us a sense of what that should look like.
Look, I think that one of the things that COVID has shown us is our capacity to reach out both in person, but also using new technology. And so the opportunity for telehealth, which of course has been available to everyone in the community, but has been used very extensively in aged care as well. And this is an opportunity to re-engage, I think, general practitioners with the aged care facilities. You don't have to necessarily get in the car and drive across to the facility in order to deliver the care which is being requested for an individual resident. We can build the telehealth into our daily work and maximise the opportunities. Now, you still have to have face-to-face consultations, of course, for the times that telehealth is not appropriate, or if you do the initial assessment, someone still needs to be seen. That's fine as well. The other thing which I hope we'll see with the primary care reforms which are rolling out or being developed across the country is more team-based care in primary care. And it doesn't necessarily have to be the GP who goes out and does the visit to the person in the aged care facility. It could be one of the practice nurses going through. But then we've got to look at, as you mentioned, the remuneration and how do we recognise the contributions and the clinical services which are being provided.
So let's talk that through. So primary care reform was about, until recently, about registering with your general practice. So the general practice had a defined population that they looked after that allowed them to use telehealth and other facilities and gain access to different means of payment. I think that's been the registration has been put on hold, I understand, with COVID-19. How's that going to evolve?
Mm-hmm. So at the moment, we have seen some evolution, and it's been linked to the telehealth. The telehealth, of course, was also going to be part of the 10-year reform. As Minister Greg Hunt has said, we implemented 10 years of reform in 10 days when we rolled out telehealth at the start of the pandemic, in order to ensure that the people of Australia were still able to access healthcare services, even as we were moving very rapidly into lockdown. One of the things that telehealth has opened up, of course, is the ability to see your patient in their own environment, in their home environment, whether they're an elderly person at home or whether they're an older person in an aged care facility. And
can I just pause you there? So does that mean, so then you want people to transition from the telephone to video?
Absolutely, absolutely. Over time, and I'm sure we'll see that. We've been seeing this occur with the telehealth move in other high-income countries around the world, especially those which picked up telehealth and supported it earlier than we have. And you're right, much of this has been by telephone, but increasingly we're seeing the use of video as well.
And how, you already have enhanced patient care items, but how's team-based care going to work in this new world of reform, which presumably you want to accelerate, given that you've got a sector that needs to be healed, to be blunt?
Absolutely, and we know the benefits of team-based care in primary care, especially in the management of people with chronic conditions, which of course includes many elderly people in our community as well. We know the great contributions that nurses can make in primary care, that allied health professionals can make, that mental health professionals can make, non-prescribing pharmacists can make. The benefits. The benefits are there. The challenge is, how do we fund these multidisciplinary primary care teams to support the population? How do we do it in a way which means that some people, that everybody gets access and that some people don't miss out? As you mentioned, I've been based in Canada the last 3 years, based in Ontario. Ontario rolled out family health teams, multidisciplinary teams, bringing together groups of family doctors with other health professionals, and they ran out of money and impetus after they'd covered a third of the population. So you get a third of the population getting the benefits of this great multidisciplinary team-based care, and 2/3 of the population who can't get to see a physiotherapist, can't get to see a psychologist, can't get to have medication reviews. Very inequitable system in a country which prides itself on fairness.
So what's in your head? Capitation? What?
Well, I think there's still a lot of water to go under the bridge before we work out what are the funding models which are going to work in Australia. We've seen the introduction of different forms of blended payments with the practice incentive payments and others, which have enabled past governments to carry out some of the reforms in primary care over past decades. The thinking around what happens with voluntary patient enrolment was looking at a form of capitation, if you like, which, as you say, has now been shelved as we move through the pandemic. But we've moved with telehealth now in its second iteration since the beginning of October, that in order to get access to telehealth item numbers under the MBS, the patient has to have seen the doctor, the GP, or someone else from that general practice in the last year, which is encouraging that linkage to a principal practice. The idea behind that, of course, is to promote improvements in continuity of care. Again, we have the evidence base to show us that where we have continuity of care, we get better healthcare delivery, better healthcare outcomes.
And how differentiated is your thinking between people who are in residential aged care, which obviously with COVID-19 is high risk, but older people want to stay at home, they want to stay in the community. How differentiated is your thinking between the needs of older people at home versus residential care?
Well, I think you've touched on one of the areas where we do have inequities. So everyone who goes into residential aged care has a general practitioner who is signed up to them, whether it's their previous GP or whether it's somebody who attends the facility where they're living. But we don't have that same equity of access for many older people in the community, and particularly as home visits are increasingly unusual. We don't have great integration between home-based aged care services and primary care services. We have some integration with some of the visiting nursing services, but we can do a lot more to get better integration of care for elderly people who are at home. One of the challenges is that many elderly people in their own homes are no longer mobile, and they can't get out to go and see their GP in their clinic, or they can't do it easily anymore. And the same, of course, applies to younger people with disability who are in their own homes and have the same access challenges. So again, telehealth has opened up this opportunity to get at least telephone access for many of these people. And as we've mentioned, I hope we're going to see more and more video access. But I think we also need to look at how do we break down the walls of our clinics in ways that means that we can provide care to everybody.
And there's a push on to integrate palliative care into residential aged care and indeed community-based care, given that people need symptom control. Palliative care is very, very good at symptom control. GPs are good at it when they engage with it. And it will presumably reduce the appalling rate of antipsychotic prescribing, which is devastating. What are the plans there in terms of bringing palliative care into an environment where people are actually going to die in that environment, and you want to die, you want them to have this higher quality of life before that, and palliative care can do that?
Yes, so very, very important, and it's been an important feature of the COVID-19 response as well, is the involvement of palliative care and making sure that palliative care services have been able to continue even in those areas of the country which have been under lockdown. And moving ahead, you're exactly right, Norman. I mean, palliative care is a core component of good general practice in Australia, of good primary care, and of course it already exists in many aged care settings across the country, and in home-based settings as well. And GPs are often involved. Sometimes they're not. Sometimes it's palliative care teams, depending on the services which are available and funded in the area where you may be living at the time. But personally, I'd like to see a lot more integration of palliative care as well as personal care in the provision of primary care.
So we'll come back to a lot of these issues. By the way, I should have said it earlier to people watching, is that if you've got a question or a comment, could you put it in the Q&A box rather than the chat box? I know you're not using either at the moment, but whenever a question or a comment occurs to you, put it in there and I'll try and bring it into the conversation when I can. Don't wait until a question and answer session at the end, because you might be too late. So put it in whenever you're thinking about it, and don't hesitate. So Sue, what's the big thing that you've walked away with here, both in a metropolitan and a regional practice in geriatrics?
I think telehealth's really, really important. I'd been doing it to Armidale for 9 years, doing a dementia clinic. So it was in northern Sydney, doing telehealth to residential aged care facilities about 2 years ago, simply because sitting in traffic to get to facilities was just crazy. And we found it worked quite well, and we could link the GPs in. So I think for the future, thinking about what we've learned, we are just so much better with telehealth. As Michael said, we've now got reimbursement for it. So you're not making that quick phone call to a patient to check on them. You're actually getting paid for doing it. And we've been doing a bit of that.
So just to interrupt there for a sec, sorry, Sue. There's been a lot of discussion in mental health about how a consultation on telehealth, a session on telehealth, is not a normal session. But you've actually got to learn how to do it. It's not just a quick chat. It's not just thinking you can get through stuff you got through before. How much have you had to learn about how to use telehealth productively and get something out of it for you and for the patient?
Yeah. We actually found some information from Canada, actually, Michael, about 8 years ago on how to do it properly. And New South Wales Health were very positive. Deb Piccone, who was then Director General of Health, was very encouraging about how we would use it. So it was old-fashioned technology and often broke down, but we learnt about how you speak, it's not the same as face-to-face. And I think that's important. And one thing I think we should be very careful about is that we combine both visits to the doctor, which the patient and the doctor really value, that face-to-face contact. You can combine it with the telehealth, with the telephone. And for me, it's been more the telephone in between. And older people want that. I've been asking them ever since I was invited to be on this. I've been asking my older patients, what was good about COVID, what was bad, and what they'd like in the future. And the telehealth side of things has come up quite often. It's quite interesting what older people think. They also realise none of them have got flu, and they think, therefore, that the social isolation may not be such a bad thing. because they are much healthier. And as one patient said to me on Friday, the pressure's off. We haven't got lots of people visiting. It's interesting. We think of it as a negative, but there's a lot of older people out there who've actually done really well during this pandemic.
Before I ask you all sorts of other things, how did you win your Emmy?
So I don't know if people who are watching watched Old People's Home for 4-year-olds, which was a series on the ABC last year, but it won an award in Australia and at the New York Film Festival, and overnight it won at the International Emmys the Best Non-Scripted Entertainment. So for a no sex, no violence, no bad language series about older people and children, I think it's just amazing. And what it did was, I think, really illustrate the wonderful relationship between generations and the benefits to both older people and children. I mean, the work on frailty that we've been doing for years, my colleagues say, if we could get the same results as you got in 7 weeks on TV, and they were real results, we measured people at the beginning and the end. If we could get those in a normal, say, rehabilitation program, we would be laughing. And I think what it illustrated was you can do some exercise at home, and we were talking about the fact that older people not getting out led to deconditioning, and they became weaker and frail. A lot of them took on board the sitting to stand, the dancing, the exercises that you can do from the series. So we've seen not just the international awards, which is great, particularly for the executive producer, Deb Kuhl, but I think the lessons that everybody's learned. And the fact that Stan and the other, whatever it is, Netflix, have taken it on and shown it means the message is getting out there, Norman, that, you know, there's really good things we can do simply.
So speaking of things that you can do, but maybe not simply, the outbreak in Victoria seemed to illustrate, the fact that, you could say, oh, there's one, if you've got one aged care facility with a big outbreak, you say, well, it's a bad egg, there's wrong. But when you've got 100 odd, there's something systematic and systemic with aged care, residential aged care, which presumably could occur anywhere in Australia, given that it's systemic. What's your analysis of what went wrong and what needs to be fixed up if it's not already been fixed up?
Look, I'm going from personal experience with the Dorothy Henderson Lodge outbreak, but also looking at the review of the Newmarch House outbreak, which was the one in New South Wales where 19 people died. And one of the big things that was identified was that no one was in control, no one was making decisions. And you made the comment earlier about the Aboriginal communities that took control and did not get infections. And I think that's been the lesson. There actually were aged care facilities that when they had an outbreak took control, and they actually transferred the residents to hospital, and that was the end of it. They had a really good plan in place. So you said before there were bad eggs and good eggs. I think that's true. There were people who were prepared. The facility where my mother is has had a pandemic plan since 2009. And they really just had to refresh it, which they did early in the year, and then it clicked into place. And we saw that in Melbourne at Caulfield, where there was a possible outbreak. Within 5 minutes, that particular facility closed and the staff knew what to do. And I think being prepared is a huge part of it. But the lesson we've learned is you need to have someone in control. And I think that was very clear from what Michael said. Working within Northern Sydney, and this is talking about the health aged care interface, which, because we have 122 aged care facilities in our local health district, for us is very important. We've had an outreach team since 2005 to aged care facilities. And incidentally, we now have a nurse practitioner in palliative care as part of that outreach team to aged care facilities, from health to aged care. And that interface, I think, is really strong and certainly could be done elsewhere. But it's having a team that knows what they're going to do. And we know in Northern Sydney Who will take charge? We've got an infectious diseases physician on call 24 hours. The rest of us are involved. I think it's that we have learnt so much from what happened in Melbourne. And I think they didn't get the notice they should have had. And interestingly, remember they were all asked by the Quality and Safety, the Aged Care Quality and Safety Commission, not to be confused with the Aged Care Royal Commission, but the regulator asked all the facilities in March around Australia, were they prepared? And the vast majority said I can't remember the words, but they were very prepared or, pretty reasonably prepared. Well, that certainly didn't happen. So I think we've learnt a lot about how to do it properly, and we need outside help. And I think we have to call for help if we need it, and we have to work together. Locally, we've worked with our GPs through our PHN and our residential aged care facilities to get a group of GPs who are happy to go in to facilities if GPs have to pull out because of age or illness. And I think that working with the primary health network, that link between health, state-run health and Commonwealth-funded aged care is really important. Sorry, I've blabbered on now.
Is it going to make a difference, though, to some of the core problems of aged care moving forward? So if you talk to people in emergency departments, they'll say, people think that the problem in an emergency department is between 9 p.m. and 9 a.m. overnight. And they say, no. The problem is 3 o'clock in the afternoon, an ambulance arrives with somebody from an aged care facility with no notes, no letter, and that clogs us up. And if we get 2 at 3 o'clock, you can just see the effects on the ED. And they go into delirium. They shouldn't be there. They should be treated at home. And you get the acute system either trying desperately to get outreach going into these facilities, or they resent the aged care sector deeply. Is there something going on in post-COVID that would make the healthcare of people in aged care better?
Certainly, the scenario you just described was what we had in the early 2000s where I work at Hornsby, because we are a very old area. We have more aged care facilities and I think more aged care residents than anywhere else in Australia. So we jumped in way back in 2005 and developed the outreach service. So we went and provided care, and we're still doing it, in our local aged care facilities, and we've got really good buy-in from the GPs and the facilities. So it means when you come to the emergency department from a facility, you come with information, and we know you're coming, and we will expedite that, your move through. If you've fallen and you may have a hip fracture, we get you into the radiology department really fast. So it's working out how to get the most vulnerable people through as quickly as possible.
So that's Hornsby, but what about the rest of Australia?
Yeah, why aren't the rest of Australia doing this? This is where we need to interface really well, but it's state funded, our outreach team, not Commonwealth funded. And I think it's developing those links, because we know there's a real antipathy, maybe is too strong a word, Michael, I don't know, but there is this negativity between state health departments and Commonwealth health departments, and ne'er the twain shall meet. And older people are the really big losers when it comes to this. So we're quite happy to provide the care. I think as a state-funded health person, we should be providing care to all our older patients when they need it, when they are acutely unwell. And I think the Aged Care Royal Commission has come down on the side that acute problems belong to the state health system. The care and ongoing care of chronic problems perhaps are managed more in residential aged care. But it's working out that interface, and that is certainly being addressed by the Aged Care Royal Commission into, the differentiation. And I mean, it does come down to who pays.
Hannah asks, would My Health Record help solve some of these problems, the wider use of it?
Yeah, and look, we like to be able to use it in our emergency department, but a lot of people don't have it. We're still we have a yellow envelope, which is the envelope we get the aged care facilities to put all the information they've got, the person's advanced care directive, their current medication, all that sort of thing. We're still at that paper and pencil, almost snail mail stage. I think the sooner we get more buy-in to My Health Record will be really, really good. And Michael might want to comment on that. I think it would be wonderful if we actually had people's current medication lists. As it is, we have to go and ring the pharmacy. They get their Webster pack.
But everybody's got a My Health Record, and their prescriptions are in there automatically. You should be able to interrogate it.
And a lot of people don't want you to download it. It's very, very interesting. The resistance is quite significant. I mean, people said to me I was crazy to use My Health Record myself. And I said, yeah, but one day I might be really grateful someone knows my past history. And I think we have to make it clear to lots of people. The PHN our PHN Sydney North has really encouraged its use. But, you know, people are suspicious. They wonder what it's going to be used for. And I think we've got a bit of work to do there. Maybe post-COVID, Norman, that's one of your things, to get people actually understanding. What's that?
One of my things.
Well,
I'll have a My Health Record Coronacast, shall I?
Well, people listen to you. You know, it is, and I think it's important.
Another question here for you. Is how are older people being supported to manage the transition to virtual care, telehealth, given that they're often less used to the technology platforms?
Yeah. Look, I think we forget that older people have used telephones all their lives, and we mustn't forget that they can do that. So your telephone's your backbone, but a lot of older people now use iPads, and teaching them how to do FaceTime is what we've actually spent quite a little bit of time doing. We try and get family members involved. If we can't get family members involved, you get neighbours involved. Now, clearly COVID's put a bit of a stop to that, but older people can be talked through how to link, say, to Zoom if they've got a computer, or to FaceTime. It is working. And I think we forget that older people can learn new things, and too many people think they can't. But I think a recent survey showed that something like 80% of people who are 80 are quite comfortable using at least FaceTime. I think the COVID pandemic's really increased that, because how do they see their children and grandchildren?
And briefly, how differently have you experienced it in regional New South Wales, where you work in Batemans Bay?
In terms of
post-COVID community aged care?
Look, the Batemans Bay and Moruya had just experienced the worst bushfires on record, and they bounced back from that, you know, and had 2 weeks or something, and then COVID hit. I think my comment would be older people are incredibly resilient, and they deal with things, and they know that this too will pass. I've heard that quite a few times. And they haven't seen COVID as all negative. The comments that I hear around the neighbourhood involvement with older people, the other interesting one is that families suddenly remember they have older relatives and use the telephone. And so there are people who might have seen their families once a month who are now being telephoned by their families, you know, twice a week. So those sorts of positives are coming out. And when I've asked patients, there are many more positives than negatives, I would have to say. The main negatives are can't go to the club. Well, after the Soldiers Club got COVID, none of them want to go back to the club anyway. And I think that was that, and not being able to go to a number of their social clubs and outings. They were the negatives, but the positives were the development of things like telehealth, the fact their groceries are delivered and they suddenly find that's quite easy to do, the fact that neighbours are stepping in to help.
Thanks, Sue. We'll come back to you with the question and answer. Please, all participants, could you just, so everybody watching, when you've got a question or comment, please put it into the Q&A box and we'll come to it as you've just heard me do. So, Stephen Jullin, what do you think are the key issues that we need to consider now moving forward from your point of view, given your background in the industry?
Thanks, Norman. Just a couple of things, if I can comment first in relation to Michael and Sue.
You want to turn on your video, Steve?
We can't see you, Steve.
Yeah, I don't know why. Off, on.
We saw you there a moment ago.
Can you see me now?
No.
Something's playing up. I'm sorry.
You're on. Don't
Okay.
touch anything. Don't touch anything.
Don't touch anything. So I just want to comment on a couple of things. First of all, Michael absolutely sort of focused on the primary care sector. It's important to understand that our work with the department over the last 8 months has told us that PHNs are doing significant work in this area, working with aged care, but while it's a priority, it's not actually funded. So there isn't funding for them other than in small pockets. So they're being asked to approach that priority and encourage commission services in that area without any general funding for that activity. And so I guess what we've been doing, working with the department around that, is to do a stock take of all the interface programs like the ones that Sue talked about, the outreach. We identified over 200 programs by state and territory health services and PHNs across the country, but all done in their own places, some brilliant activities done locally and not spread across the country. And so the department asked us to actually look at those and say, where could we expand the role of PHNs? And where can we work with state and territory health services to actually improve that interface? And I have to say, both with the 31 PHNs, with every state and territory, there was a significant sense of cooperation and a genuine interest in actually trying to improve that interface and look at the areas where they could do that.
But what is it that PHNs can do? I mean, you can imagine Medicare locals that actually did stuff themselves and got resources. But PHNs are commissioning organisations. So what are they? What do they commission?
They commission things like in-reach services between the primary care providers and the aged care facilities. They commission telehealth arrangements. They commission both in terms of they commission after-hours support services, so that there is access to emergency consultations after hours by the residential aged care facilities. A myriad of different things that they do to actually support that. They do some work in areas like chronic health assessment programs and being able to support multidisciplinary teams. There is a lot happening across the country, both by state and territory health services and PHNs, that is not really recognised. This is the first stock take ever that's been undertaken. And the key question then is, which ones of those should be supported to be expanded? And there are certain roles that PHNs can play, for example, in actually making sure that GPs understand the different services which are available and the pathways to use them, or how to engage in multidisciplinary teams for the chronic health assessments and the planning, implementation of that. Many things can be done, and PHNs can be key players in that, but they actually need to be funded. So one of the things that I know the department is looking at is both at the PHN level and state and territories, how they can move forward to actually address some of these pretty significant gaps and build on the strengths that already exist in models like Sue's model, the outreach model, or geriatric flying squads, or JEDI in Queensland, which is a concierge service for older people going into hospitals, taking them through the ED, introducing them to the wards, getting them discharged quickly. All of these things are happening, but they're happening on a local basis, not at a national level.
But just coming back to Sue's point about when COVID hits, somebody's got to be in control. One of our great problems in Australian healthcare is fragmentation. We're not alone internationally with that. But we set up these parallel activities and nobody's in charge, nobody's in control, nobody's coordinating, but you feel good because you've got an in-reach service, but nobody's talking to anybody else.
Well, I think that's where I don't agree with that. Now, I think they now are talking to each other. I think the Royal Commissions probably help with that, but there is dialogue occurring between the Department of Health, the Australian Government Department of Health, all the state and territory departments of health about what needs to be done to improve that interface.
That's not the talking I'm talking about. I'm talking about on the ground. So I'm talking about you've got PHNs commissioning this, that, and the other. I'm not diminishing what they're doing in any shape or form, but that was a specific question I asked you. But you've got these parallel activities. Who coordinates on the ground? Because you can't rely on my aged care to do that, and people drawing it down to themselves. That doesn't seem to be working that well in the system. much as it's a nice aspiration. It's not working that well in NDIS either. So who is the responsible entity? Where do you get coordination from? In other words, this obsession with PHNs being commissioning organizations kind of missed the point that PHNs could be that coordination, but that would require them to do something actively rather than commissioning it out.
Well, let me give you an example. So in Victoria, there's an organisation that commissions, a PHN that commissions after-hours emergency services into residential aged care. If they hadn't commissioned that, that would not have happened, and they've organised it across all the residential care facilities in their region. That is where a PHN is actually providing that coordinating activity in the local region. The challenge is that that is not occurring across Australia, but within that region, it's actually making a significant difference.
And what about just addressing the acute sector and the interface there?
Yes, well, again, there are those issues around, as Sue mentioned, outreach to residential aged care, access to palliative care, those types of things. Again, we identified many of those models around the country, but there needs to be a commitment between the Commonwealth and the states and territories as to how those programs will be implemented. And we understand that those things are being seriously considered and discussed at the moment.
Michael, do you want to comment?
Make sure I'm on. Yep. Look, I think we've actually seen a number of PHNs really step up. And I've been in a number of these webinars with Inez Rio, who is the chair of the Northwest Melbourne PHN, where she's talked about what her PHN was doing during the Melbourne second wave, and the support being provided, making sure that the residential aged care facilities in that part of Melbourne did have access to GPs, particularly because, as has been mentioned, many of the GPs themselves were elderly or vulnerable, otherwise vulnerable people. The support which was provided to the tower blocks when the tower blocks were locked down in Melbourne, and the extraordinary mobilisation of local GPs and other primary care providers to reach out and support the people who found themselves in that very scary situation in that area. So, you know, I think we're seeing some wonderful examples, and I think that during the pandemic, we've seen many of our PHNs really step up to the mark and take responsibility for coordinating care in their local communities, as we've seen so many of our primary care providers step up and look after their individual patients in their communities.
So the Commonwealth's comfortable with that more proactive position, because some PHNs tell me they feel neutered, they don't feel able to go out there. You know, obviously Northwest Melbourne feels confident and able to go out and do that. Some PHNs tell me, oh, what will the Commonwealth say if I do that? You know, feel nervous about it.
Well, the two PHNs in South Australia have been very active over the last week with the outbreak that we've seen in that state, and you know, I'm not involved in the individual contracts with individual PHNs, but I think that the examples that we've seen may help to set some paths for what happens in the future.
And, you know, picking up on what both Sue has mentioned and Steve, Michael, how do you spread success? I mean, there's a Nobel Prize in this, but how do you spread success, and what incentives do you put in the system to say, well, you know, terrific things are happening Northwest Melbourne or South East Melbourne or South Australia? How do you get it to spread?
Well, I think partly through having role models and through highlighting what other people have been doing gets the rest of us to think, oh, maybe I could be doing that as well. I think that one of the things the Commonwealth has been doing is getting the CEOs of the PHNs together on a very regular basis throughout the pandemic, together electronically, of course, not physically, and talking about what's happening and talking about the challenges that people are having and listening to each other and learning from each other. And so you do get this, that there's been a lot more engagement between the individual PHNs during the pandemic than there has been before, which again, I think gets people thinking about, okay, well, they're doing that, we can do this as well. The PHNs, as I mentioned right at the start, have been very proactive in putting up their hands and saying, yep, we'll go out there, we'll identify the places where we need these GP-led respiratory clinics to support the COVID effort. We'll be involved in the distribution of personal protective equipment, something the PHNs, of course, had never done before. So I think that, we're seeing incremental changes. We're seeing people coming together. We're seeing the role models setting some examples.
And My Health Record, just coming back to that issue, it's close to your heart. You spend a lot of time on online health, digital health. You believe in it passionately. How do we change attitudes towards My Health Record? Not everybody's got one. It's just not necessarily used.
Well, I think it's interesting to look at the figures for the last 12 months, and particularly since COVID has been around, with the documentation, the dramatic increase in the number of documents that have been stored on My Health Record, the very substantial increase in the number of people who've actually accessed and had a look at their own record. Again, this may be a reflection of people spending a little bit more time at home and less time commuting, suddenly thinking, hey, I've got one of these things, I'll go in and have a look at it and see what's on there. The increase in the utilisation by healthcare providers has happened as well. So I think again that there's got to be a tipping point for My Health Record, and I think that perhaps we're approaching that as well.
Actually, I was hearing that the bushfires gave it a spur along, because people who were in those, particularly those South Coast towns, who had My Health Records were much better off than those who didn't, because they were able to get the prescriptions and what have you.
Absolutely.
Another question for you, Michael. You just got to accept the fact you're here. People can ask you questions. Do you sense that the government is committed to the sustainable funding of telehealth and primary care? What other emerging technologies could reasonably and safely enhance telehealth? For example, remote monitoring devices, which we've been talking about for 20 odd years.
Yes, so as you know, in the October budget, the telehealth initiative was extended for another 6 months. So we currently have telehealth funded through the MBS until the end of March. Minister Greg Hunt has been speaking in public about his views about the future of telehealth. Someone else was at a talk last week described as a genie in a bottle. That's the bottle's been opened and the genie is out there. Exactly what format it will be in is still to be determined beyond the end of March next year. But certainly the population has really embraced the use of telehealth, and healthcare providers have too. I was really stunned and impressed by how quickly we were able to change the model of care delivery in Australian healthcare, especially in general practice, but by many other healthcare providers as well during that 10-day period at the start of the pandemic. And you're right, there's all sorts of digital things happening. We've got the e-prescriptions happening as well. We've got people looking at when people have been diagnosed with COVID-19, can they get their monitoring remotely? We've seen that happen in a number of other countries with oximeters and available at home. And why shouldn't that be utilised in other ways? And, there's been a lot of research in the past looking at telemonitoring, particularly of frail elderly people living on their own, in their own homes, and seeing which rooms they've been to, and have they been up and down to the bathroom, or are they just in the bedroom? And is that a red alert that somebody needs to be visiting? So I think we're going to see a lot more integration of e-health, and this will be part of the, if you like, the flow on from the pandemic. We've seen a lot of innovation occurring. We've seen a lot of embracing of that innovation, and I'm sure a lot of it is here to stay.
Steve, a question for you. You talking to the Commonwealth, what's intended to be done with the stocktake?
There have been a set of recommendations put forward, Norman, about things that might be able to be expanded by PHNs on one hand. And
do you want to just try your video again? We love seeing you.
Can you hear me? See me now?
Yes.
Yes. So there's been a set of recommendations. Provided to the department for consideration to expand. Some of those are for PHNs to implement. Others are for state and territory health services to implement. They are currently being considered, we understand, by the department, and hopefully as part of the response to the Royal Commission, they're going to get very serious consideration.
So just in terms of, I just want a quick comment from each of you as we close about what you think is the highest priority action that needs to be taken moving forward from COVID-19. Steve, you've got the screen. I might well start with you in the aged care sector.
I think in terms of short term, making sure that the aged care services, residential aged care services, actually have their infection control under control is the most important step. In the longer term, I think actually being able to align health services with the home care system, because there's very limited, virtually no alignment between those two at the moment, that should be the longer term goal.
Michael?
Oh, certainly the protection of the most vulnerable people in Australia during the pandemic has to be our priority. And of course, many of those people are living in residential aged care facilities, but many others, of course, are living out in the community. And we can't take our foot off the accelerator. We've got to keep looking at continuing improvement throughout our aged care services.
And Sue?
Yeah, I'd agree with both, you know, what's been said, but I think working together is the really big thing. And if we, and you know, Norman, I've been quite involved with the Royal Commission, the Aged Care Royal Commission, and getting state and health to, you know, state health and aged care, Commonwealth Health to work together is really, really, really important, because that will benefit those incredibly vulnerable people. And it will be us one day. And I want to make sure when I need to go into care that it's a really well integrated service and not the way it is at the moment.
Look, thank you all very much indeed. It's been a fascinating discussion, and I'll hand back to Ian.
Thank you very much, Norman, and special thanks to Sue, Michael and Stephen for your participation. Sue, I would just kind of reiterate Norman's congratulations about the Emmy and urge anybody on this call who hasn't seen the programme to catch it now. It is on several channels and well worth the investment. Just to wrap up a couple of things, I'd just like to remind everybody who's on this call, if you have bought a series pass to these webinars, but the next one will be next Tuesday, please do speak to colleagues and acquaintances to mention how valuable and how interesting these conversations have been. Next week's conversation is going to be particularly pertinent given the recent news coming out from the US and from the UK around the vaccinations. It's going to be looking at the implications of a vaccination and the rollout across Australia. I think Michael is joining us again for that session. We would like to remind everybody that this is for a great cause. So Youth Focus do great work in regional WA working with disadvantaged young children. So we want to thank everybody for buying access to this, and hope you can spread the word. Just do mention to everybody that if you do sign up to the season pass, you will get access to the recordings for both this conversation and last week's conversation on the impact of COVID on those who suffer long-term symptoms from COVID post the initial infection, during which time Norman interviewed somebody who's been suffering from COVID for over 7 or 8 months, and it was a fascinating insight. So with that, I'd like to wish everybody a good afternoon and a good evening. Thank you very much for joining us, and we look forward to hosting you again next week. Thank you.